Malcolm X sits in a Chicago emergency room with acute pain. The white doctor walks in, glances at him, assumes he's exaggerating for pain medication, speaks to him like a parent to a child, explains in simple words that some people just have low pain tolerance, says Malcolm should go home, take aspirin, stop wasting emergency room resources. Malcolm remains calm, asks the doctor if he checked for peritoneal signs. The doctor says that's not necessary. Malcolm describes rebound tenderness in his lower right quadrant using exact medical terminology. The doctor orders immediate tests. Results show Malcolm was right. But before we learn what those test results revealed and what could have happened if the doctor hadn't listened, if you appreciate stories about moments when assumptions nearly cost someone their life, when prejudice interfered with professional judgment, please subscribe to this channel. Hit that like button if you believe medical care should be based on symptoms and evidence, not assumptions about a patient's intelligence or honesty. These stories remind us that bias doesn't just hurt feelings, it kills people. Now let's find out exactly what was wrong with Malcolm and why the doctor almost sent him home to die. The hospital is Cook County Hospital on Chicago's west side, a massive public hospital serving the city's poor and working-class residents. The building is old, crowded, perpetually understaffed. The emergency room is a constant chaos of sick and injured people waiting for care. Saturday night is the worst. Gunshot wounds, stabbings, car accidents, overdoses, heart attacks. The doctors and nurses work non-stop, exhausted, overwhelmed, making quick decisions with incomplete information. It's 11:30 at night. Malcolm has been sitting in the waiting area since 7:30, 4 hours. The pain started around 6 in the evening while he was having dinner with other Nation of Islam members at a restaurant. Started as mild discomfort in his stomach. Within an hour, it became sharp, localized pain in his lower right abdomen. Getting worse. Constant. He tried to ignore it, tried to finish the meeting, but by 7, he couldn't sit comfortably. Someone drove him to the emergency room. The waiting area is packed, 30 people in various states of distress. A man holding a bloody towel to his head, a woman cradling her arm, a child crying with fever, an elderly man struggling to breathe. Everyone waiting, some for hours. The triage nurse assessed Malcolm, noted his symptoms, his vital signs, moderate fever, elevated heart rate, pain level 7 out of 10, important but not immediately life-threatening compared to the gunshot wounds and heart attacks, so he waits. Malcolm sits in an orange plastic chair bolted to the floor. He's wearing a dark suit, now wrinkled, white shirt, loosened tie. His glasses keep sliding down from sweat. The pain is getting worse. Sharp, stabbing pain every time he shifts position. He tries to stay still, breathes slowly. He's familiar with pain, spent years in prison, been beaten by police, knows how to manage it, but this is different. This pain is internal, something wrong inside his body that he can't see or control. By 10 o'clock, the pain is severe. Level 8, he's sweating despite the cold waiting room, his skin feels hot, the fever is climbing. He approaches the triage desk, asks how much longer. The nurse, overworked and exhausted, tells him they're doing their best. Gunshot victims take priority, he'll be called soon. He goes back to his seat. At 11:15, his name is finally called. A nurse escorts him to an examination room. Small space, examination table covered with paper, counter with medical supplies, bright fluorescent light. The nurse takes his vital signs again, temperature 101.5, heart rate 110, blood pressure slightly elevated. She makes notes on his chart, tells him the doctor will be in soon, leaves. Malcolm sits on the examination table, the paper crinkles under him. The pain is now constant, sharp and burning, worse when he moves. He lies back slowly, trying to find a position that hurts less, fails, everything hurts. He focuses on breathing, staying calm, not letting pain overwhelm his thinking. 20 minutes later, the door opens. The doctor walks in, Dr. Robert Henderson, white male, early 40s, been working emergency medicine for 12 years, he's exhausted. Been on shift since 3 in the afternoon. It's now 11:30, 8.5 hours of non-stop emergencies. He's seen 2 gunshot wounds, 1 stabbing, 3 heart attacks, a severe allergic reaction, a broken neck from a car accident. He's operating on autopilot, making quick assessments, moving patients through, trying to clear the waiting room. Dr. Henderson glances at Malcolm's chart as he enters. Sees the chief complaint, abdominal pain. His immediate thought, based on years of emergency room experience and ingrained bias, is that this is probably nothing serious. Young black man complaining of abdominal pain could be drug-seeking behavior, could be exaggeration, could be simple indigestion or gas. The emergency room sees this all the time. People coming in for minor complaints, demanding pain medication, taking up resources needed for real emergencies. He looks at Malcolm, takes in his appearance. Black man, mid-30s, wearing a suit, sweating, claims to be in pain. Dr. Henderson's assumptions activate. He's not consciously racist, would never describe himself as prejudiced. But he has patterns in his thinking, shaped by years of seeing certain demographics present with certain complaints, and those patterns tell him this probably isn't serious. His demeanor is dismissive before he even begins the examination. He asks about the pain in a tone that suggests he doesn't quite believe it's as bad as Malcolm claims, asks when it started, what Malcolm was doing, what he ate. The questions are perfunctory. He's already forming his conclusion. Malcolm describes the symptoms accurately. Pain started in the center of his abdomen around 6, migrated to the lower right quadrant within an hour, sharp, constant pain, worse with movement. Associated with nausea, low fever, no vomiting yet but feeling like it might happen, no diarrhea, no recent trauma. Dr. Henderson performs a cursory examination, presses on Malcolm's abdomen briefly. Malcolm winces. The doctor notes this, but doesn't perform any systematic examination for specific signs, doesn't check for rebound tenderness, doesn't check for rigidity, doesn't perform proper palpation, just a quick press, and he's done. He steps back, washes his hands in the sink, tells Malcolm in simple, patronizing terms that some people just have low pain tolerance, that stress and anxiety can cause stomach pain, that what Malcolm is experiencing is probably just gastroenteritis or maybe irritable bowel syndrome triggered by stress. Uses words like tummy ache instead of proper medical terminology. Speaks slowly, as if explaining to someone who wouldn't understand complex concepts. He says Malcolm should go home, take some aspirin for the pain, drink plenty of fluids, get rest. Says if the pain doesn't improve in 24 hours, he can follow up with a primary care doctor. But this doesn't require emergency treatment. They need to save emergency room resources for real emergencies. He's already moving toward the door, ready to see the next patient. Malcolm remains on the examination table. He's listening, processing. He knows what's happening, knows the doctor dismissed him without proper examination, knows the assumptions being made, knows his symptoms are being minimized because of who he is, what he looks like. He speaks calmly, no anger in his voice, no accusation, just a simple question. He asks if the doctor checked for peritoneal signs. Dr. Henderson stops, turns back. The question catches him off guard. Peritoneal signs. That's medical terminology. That's not something a regular patient would know to ask about. He reassesses Malcolm slightly. Maybe he works in healthcare. But no, the chart doesn't indicate that. He decides Malcolm must have looked up symptoms online, Googled his pain and found medical terms he doesn't actually understand. Dr. Henderson says in a condescending tone that checking for peritoneal signs isn't necessary in this case, that Malcolm's symptoms don't warrant that level of examination, that he's been doing this for 12 years and knows when to do what tests. Malcolm doesn't argue, just describes in precise medical terminology the symptoms he's experiencing. He says he's experiencing rebound tenderness in his lower right quadrant, specifically at McBurney's point. Says the pain started periumbilical and migrated to the right iliac fossa within approximately 90 minutes. Says he's experiencing guarding on palpation. Says his fever started at 100.22 hours ago and is now progressed to 101.5. Says his white blood cell count is likely elevated, probably around 15,000 or higher. Says these are classic presentations of acute appendicitis and that if the appendix ruptures, he'll develop peritonitis, which has a mortality rate of approximately 15% even with treatment. Dr. Henderson stands frozen, staring at Malcolm. This is not what he expected. This is not someone who Googled symptoms. This is someone with medical knowledge, real knowledge, using correct terminology, describing the clinical presentation of appendicitis more accurately than some medical students could. Dr. Henderson's face changes. The dismissiveness vanishes, replaced by concern and embarrassment. He just tried to send home a patient who might have appendicitis, who might die if the appendix ruptures, who was describing symptoms correctly while the doctor ignored them. He approaches Malcolm again. His tone is completely different now, asks permission to examine him properly. Malcolm nods, lies back down. Doctor Henderson performs the examination he should have done initially, palpates the abdomen systematically, checks for rebound tenderness, presses down on the lower right quadrant, then releases quickly. Malcolm's face contorts in pain as the pressure releases, positive rebound tenderness. Classic sign of peritoneal irritation, checks for Rovsing's sign, presses on the left side, Malcolm feels pain on the right side, positive. Another indication of appendicitis, checks for Prosing's sign, asks Malcolm to lift his right leg against resistance. Malcolm winces, positive. Checks for abtortion sign, flexes and internally rotates Malcolm's right hip, pain, positive. Every test is positive. Every sign points to acute appendicitis, and Dr. Henderson nearly sent him home with aspirin. Dr. Henderson steps back, tells Malcolm he's ordering immediate blood work and a CT scan, says they need to rule out appendicitis, says Malcolm will need to be admitted, possibly surgery tonight depending on the scan results. Malcolm nods. He already knew what was wrong, has known for hours, but he needed the doctor to figure it out because patients can't admit themselves to hospitals, can't order their own tests, can't perform their own surgery. Dr. Henderson leaves the room, orders stat blood work, calls radiology for an emergency CT scan, calls the surgical team to put them on standby, writes urgent in large letters on Malcolm's chart. The patient he dismissed 30 minutes ago is now a priority. A nurse comes in, draws blood, starts an IV line, gives Malcolm IV fluids and antibiotics. The antibiotics are precautionary. If it is appendicitis, they want to start treatment immediately to prevent infection from spreading. If the appendix ruptures, the blood work comes back 20 minutes later. White blood cell count 16,200 elevated, indicating infection and inflammation. Malcolm's estimate of 15,000 was close. The rest of the blood work shows signs of systemic inflammation. The CT scan happens at 1 in the morning. Malcolm is wheeled on a gurney to radiology, lies still in the scanner while images of his abdomen are taken, returns to the emergency room to wait for results. Dr. Henderson reviews the CT images with the radiologist at 1:30. The appendix is clearly inflamed, enlarged, thick-walled with surrounding fluid. Classic acute appendicitis. Not ruptured yet, but close. The radiologist notes that another few hours and it likely would have perforated. Dr. Henderson returns to Malcolm's examination room, explains that the CT confirmed acute appendicitis, that surgery is necessary, that the surgical team is being called in, that this is time-sensitive, that Malcolm was right about everything. Malcolm asks what would have happened if he hadn't spoken up, if he'd just accepted the initial diagnosis and gone home with aspirin. Dr. Henderson is quiet for a moment, then says honestly that the appendix likely would have ruptured within 6 to 12 hours, that Malcolm would have developed peritonitis, that he might have died before getting back to the hospital, that at minimum, he would have required emergency surgery with much higher risk of complications. Malcolm nods. He already understood this. He asked the question to make sure the doctor understood what his assumptions almost caused. At 2:30 in the morning, Malcolm is taken to surgery. The surgeon is Dr. Patricia Chen, an experienced general surgeon called in from home. She performs an emergency appendectomy, opens the abdomen, finds the appendix inflamed and on the verge of rupture, removes it carefully, checks for any signs of perforation or infection spread, finds none. The surgery is successful. Malcolm was caught just in time. Recovery takes a week. Malcolm stays in the hospital for 3 days post-surgery. During his stay, Dr. Henderson visits twice. Not required. He just comes. The first visit, he apologizes. A real apology, Says his assumptions almost killed Malcolm. Says he's been thinking about how many other patients he's dismissed because of bias. How many people he sent home who shouldn't have been sent home. Malcolm says the problem isn't one doctor. It's the whole system. Medical schools don't train doctors to recognize bias. Hospitals don't have safeguards. Patients from marginalized communities learn not to trust doctors because of experiences like this. The system creates conditions where bias becomes life-threatening. Dr. Henderson asks where Malcolm learned medical terminology. Malcolm explains he educated himself in prison, read medical textbooks, studied anatomy, physiology, pathology, not to become a doctor, but to understand how bodies work, how systems work, how power operates through institutions like medicine. He says this knowledge saved his life, but most people don't have this. Most people trust their doctors, wouldn't know to push back, wouldn't know to ask about peritoneal signs, would have gone home with aspirin and died. The second visit, Dr. Henderson brings medical journal articles about racial bias in emergency medicine. Studies showing Black patients are less likely to be believed about pain, more likely to have symptoms dismissed, more likely to die from conditions that should be survivable. He asks if Malcolm would speak to the emergency department staff. Malcolm agrees. 2 weeks later, he returns to Cook County Hospital, speaks to emergency department staff, tells his story, explains that bias in medicine isn't just individual prejudice, it's patterns of thinking reinforced by medical education and hospital culture, mental shortcuts shaped by stereotypes, and those stereotypes kill. Some staff are defensive, say they treat everyone equally. Malcolm points out that not seeing color means not seeing different experiences, that Black patients face systematic barriers to care. Others are receptive, want to understand how to do better. Malcolm suggests concrete changes, mandatory bias training, protocols requiring specific examinations, patient advocacy systems. The hospital implements some changes over following months. Bias training becomes mandatory. Protocols are updated. Dr. Henderson becomes an advocate, using his mistake as a teaching example. Years later, after Malcolm's assassination, Dr. Henderson writes an article for a medical journal, titled "The Night Malcolm X Saved His Own Life: Lessons About Racial Bias in Emergency Medicine." He describes the encounter in detail, uses it as a case study about how bias affects medical decision-making. The article is widely read, gets cited in other papers, becomes part of medical ethics curricula. The article's conclusion is simple. Malcolm X survived because he had medical knowledge most patients don't have, because he could recognize his symptoms and insist on proper examination. But patients shouldn't need to be medical experts to receive appropriate care. The burden shouldn't be on patients to overcome their doctor's biases. The burden should be on doctors to recognize and address their biases before they harm patients. The story spreads through medical communities, gets told in hospitals and medical schools, always with the same lesson. Listen to patients. Don't let assumptions override clinical judgment. Perform proper examinations regardless of who the patient is, because the patient you dismiss might be right, and dismissing them might kill them. If this story made you think about how bias operates in life or death situations, about how prejudice doesn't just hurt feelings but ends lives, about how systems need to change not just individuals, then subscribe. Hit that like button if you believe healthcare should be based on evidence and symptoms, not assumptions about patients. Consider how many people have died because their doctors didn't listen. Consider how many could be saved if bias was recognized and addressed systematically.